Hey, hey, everybody. Hello. We're going to give it just a minute here for Kara to come in. Hi. Welcome to another episode of Inside Expert. We have moved our Inside Expert trainings over to Instagram Live, and I am super excited to have Kara Cruz joining us today. And Kara is here, so let me just add her in as a host or as a co-host. Give us just a second to get this settled. Hi, Gianna. There's Kara.
Hey,
Hi, Kara.
how are you?
I'm good. How are you?
I'm doing well. I'm hoping I don't get too many notifications, being on the phone. It's a little bit different. It's okay.
Different. Yeah, but we've got a bunch of people coming in. This is so exciting. Yes. Welcome, everybody. Thank you for joining us. I'm glad you're here. So please feel free, as Kara is talking, to drop any questions or comments you have in the comments, and I'll be keeping an eye on that, as we go. Okay, and I'll make sure that you see those, Kara.
Thank you. Yeah.
So
probably won't see them once I get going. I'll be all up here and in my.
Hi, Mackenzie.
Here. Hi.
This is so fun.
I love Instagram. I know Facebook has been a little bit challenging with the live sometimes, but Facebook or Instagram's fun.
So these trainings, if anybody is wondering why are we here, what are we doing here? One of the things that I love to do is just give people a platform to teach and to share about the things that they're passionate about. So I call these Inside Expert trainings because we don't need to go out and find guest experts. The experts are right here. So today we have Kara Cruz, and this is Kara's second Inside Expert training, but today she's going to teach us about something really important for Suicide Prevention Month. And she's going to teach us about suicide assessment and safety during the perinatal period. So please be advised, there is a content warning, trigger warning. We are going to be talking about suicide in the perinatal period. So that if that's not for you, completely understand. Otherwise, Kara, take it away.
Yeah, I know it can be a very sensitive topic, and so
absolutely,
if this, can't hear and listen to, we completely understand. I'm going to be speaking more directly to therapists or mental health professionals who are working and have training in mental health, but maybe just aren't real sure about how to go about screening during the perinatal period. Perinatal mental health, a little bit different, a little bit nuanced. And so quite often we don't get that training in grad school. But the time that we're spending together today could also be helpful for somebody who isn't a mental health professional.
Absolutely.
It's a short, it's about 15 minutes. I'm really just kind of hitting the highlights and the main points. This is something that, if you want more training, background experience on, I would recommend getting more in-depth training. So I'm going to hit the highlights. I won't be able to go too far into depth because there's just so much to teach about it. But I think it's important just to start talking about this topic.
Yes,
and raising
for sure. Absolutely. Okay. So, well, before we really get into the meat of it, Kara, let's take a second and just introduce ourselves, because it just occurred to me that there are people out there who don't know us. I'm Michelle Risser. I'm a therapist in the Central Ohio area. I work primarily in perinatal mental health as well as EMDR and trauma therapy. And I also have a second business where I provide consulting for therapists and mental health providers who want to diversify their income streams by turning their expertise into continuing education. So that's me. Tell us about you, Kara.
My name is Kara Cruz. I'm a licensed marriage and family therapist. I'm also a perinatal mental health specialist. I'm from California. My practice is 100% virtual, and I primarily work with women, not only in the perinatal period, but I work with women who have children, who don't have children. And my main focus is anxiety, trauma, mood issues, neurodivergence. And more recently, I've been talking about perimenopause because that's been something that a lot of my past clients, now that they're getting into their later 30s and 40s, have come back, that they were pretty stable and doing well. And then this new life phase happens for them and they come back to work with me. So I enjoy what I do. I love supporting my clients. I see them individually and in groups. At a group setting, I have different topics of groups that I work with, and just love what I do. And I love teaching too. And I can vouch for Michelle, your program, your CE prep program has been really helpful. It's really helped me to get unstuck and to really put things into action. So I'm currently working on the trainings that I teach, getting them CE approved, so that not only is it, therapists are getting the good information, but they're also able to count it towards their continuing requirements. So
absolutely. It's going to be soon.
Yeah.
It's going to be so soon.
Kevin.
And in the meantime, Kara is always offering trainings, workshops. She is so generous with her time and her knowledge on a wide variety of topics. So definitely, if you're not already following Kara, just click that follow button when we hop off of here. I don't know if you can do it now or, but at some point, please tap follow Kara. And if you're not following me, I'd love if you would follow me as well.
Yeah.
All right.
Well, okay, I'll just get into it.
Yeah,
so we have a little
jump right in.
So
I'm gonna put myself on mute, but I'm right here if you need me.
Yeah, sounds good. Okay. So this was really important to share this information in honor of Suicide Prevention Month here in September. I really wanted to take the time to focus on a smaller population and group of folks in the perinatal period who, when they do experience symptoms, it can be a little, like I mentioned, a little bit more nuanced. There's some differences that can come up for these folks. And so I think it's important just to share what that may look like. It's important. 1 in 5 moms and 1 in 10 dads will experience a perinatal mental health depression or experience some sort of depression in the perinatal period. And this is different than we hear about your traditional baby blues, which I'm going to talk about in a minute to kind of define. We hear lots of different, we hear maternal, postpartum, perinatal. I'm going to define that in just a bit. But 1 in 5 moms. So, I remember the first time I heard that, I was sitting in clinical supervision with other therapists. There was 8 of us. We were all women at the time. At the time, it was just a group of women for that particular week. And when we were talking about this, we looked around the room and we realized most of us were moms in that group, 1 in 5 of us. And then we started kind of talking about the statistics and realized that there was actually more than that in that particular group setting that I was in. And that was kind of the moment that really hit me that, wow, this is a really big deal. This is really important to teach about. Perinatal mental health conditions are the #1 complication in childbearing, which we don't hear about that often, which that struck me as well. And then mental health conditions are the most common complication of pregnancy and childbirth in childbirth. So we typically will think more along the lines of the medical conditions that can happen, but mental health complications and issues are the #1. And suicide is a leading cause of maternal mortality. So it is actually, it's more prevalent than a medical complication. Yeah. So,
wow, I did not realize that.
Yeah. Yeah. Those are just some things important to share because that's what really kind of stopped me in my tracks, reading that and looking back and going back and listening to a podcast or reading a book. Hold on, did I read that right? Did I hear that right? So I think it's more common than we think. And I think that what happens is it's just not talked about. And what I find that with clients I work with is even in that group of therapists I was sitting with, it had kids that were in their teens, had 10-year-old kids. We all had different ages of kids. We're all a group of therapists who know the importance of talking about mental health topics. And we don't think there's any stigma with mental health. And we weren't talking to people about it.
Mm-hmm.
We were the professionals and we weren't bringing it up or talking about it. So we're all on the same page. Perinatal mood and anxiety disorders, you may hear them referred to as PMADs, just for short. It's basically a group of different mental health conditions that can occur during the perinatal period. So I'm going to just talk a little bit about postpartum. We hear postpartum, maternal, perinatal. Postpartum is the period following childbirth and the birth of young. Perinatal mental health refers to during pregnancy, and postpartum or postpartum loss. So that when we say perinatal, we're really talking about the entirety. So pre-pregnancy, this can be during preconception, infertility, pregnancy, postpartum, and beyond. The baby blues is something that a lot of my clients will come to me saying that they went and when they decided to speak up about how they were feeling, they were told that they had the baby blues. And the baby blues is not considered a PMAD. It is actually very common. Most people who go through pregnancy, postpartum will experience a flavor of the baby blues. Yeah, it's just like you're not feeling yourself. You might feel a little bit sad, maybe a little bit more anxious, may have some sleep disturbance, maybe just kind of feeling a little out of it and just, that fourth trimester. So 80% of new mothers or parents can experience mood swings and changes that would be classified as the baby blues. But once it goes beyond about a 2 to 3 week period and it's still happening, we're looking at something, we could be looking at something different. And so it's really important that a person that, if that's them, that they get some further screening and some sort of kind of, check in with a mental health professional, a medical professional, anyone who might have a little bit more experience and have some training and background in PMADs. So the PMADs are a group of symptoms that can affect women during pregnancy and postpartum, and it can cause emotional, physical problems that make it difficult for them to enjoy their life. And before, when I first was trained, we talked about 6 PMADs. Now there's actually 7. We separated out one. So I'm going to share that in a bit. But the symptoms can begin anytime during pregnancy or postpartum. So there's not like a timing thing. It doesn't have to be, the 3rd trimester, right after. It can be anytime during pregnancy, postpartum. The symptoms can last indefinitely if they're not treated. So they often will not just go away like the baby blues. Will kind of just, once sleep is restored a little bit more, go away. And symptoms and the behavior manifestations can differ from person to person and look very different. So often we hear about this in the news. We hear about the most severe cases, which we are going to be talking a little bit about that today, but we hear more about psychosis where somebody's lost touch with reality, or severe depression where maybe somebody is having suicidal thoughts or behaviors. But there's 7 unique perinatal mood and anxiety disorders. So, and we're just going to kind of quickly list them off and then go into the screening for suicide, which is why we're here today. So we have perinatal depression, which a lot of people will kind of hear people say, I had postpartum, or I had postpartum depression. And what most people mean is they're kind of lumping them all together. But in our field, in the mental health field, and those of us who have the perinatal component training, we really separate those out. So we can see a depressed presentation, anxiety, OCD, panic is now one that they've separated out from anxiety, trauma, PTSD, bipolar 1 and 2, and psychosis. And I just want to note that severe depression, a bipolar or psychosis episode, those are very serious and can be, and psychosis can be a life-threatening emergency. And so in those cases, that's where somebody is seeing things, hearing things, has lost touch with reality. They're not themselves. They may have delusional behavior, beliefs, bizarre or unusual beliefs or thoughts. That is something that needs immediate medical attention. So as a side note, if you're even in the realm of that, that's something that the person does need to get medical attention ASAP. I was just going to check and see if there's any questions so far. It doesn't look like it. Risk factors for PMADs, just in general, the 7 that I listed, would be a pre-existing mental health or medical condition. So a mental health condition could be that they've experienced depression in the past, anxiety. We really want to keep an eye on that. If they have a bipolar diagnosis, ADHD, anything that's disrupting the mood, whether there's severe mood dysregulation, or a psychosis diagnosis. If somebody has a pre-existing schizophrenia diagnosis, we really want to keep an eye on these people. Medical conditions can be a risk factor. Disrupted sleep is one of the top things that I start working with clients on. A history of abuse, substance abuse, lack of social support, and unwanted pregnancy, or a previous psychiatric contact or hospitalization, meaning that they were inpatient, hospitalized, or they had gone to an emergency department because they were having thoughts of hurting themselves or hurting others. And if they've had a prior suicide attempt, those would be risk factors that we really want to keep an eye. Anytime as clinicians, therapists, we see that, when we're doing, working with a client for the first time, those are going to be just little things that we are really paying attention to and going to ask more questions. Protective factors, there's many, but I just want to kind of list off that if protected sleep is really important, and having the village, a social support circle, and then care and treatment of any of the prior conditions that I mentioned earlier. So if they're receiving care, treatment, and they're stable in those other conditions, that can be protective for them. Okay. Some considerations when screening is that, suicidal ideation, there's a range. We can go from suicidal ideation, a thought, an intrusive thought that comes up where the person has never had an attempt, never had a thought before. The thought scares them. They don't want to act on it. We might call that something like more in the passive ideation, or where a person thinks, you know what, maybe it'd be just easier if I weren't here anymore. Life is really hard. I don't have the energy for it. All the way to active ideation, where the person has a thought of suicide with a plan, intent, and means to harm themselves. So if we think of kind of a continuum of, when somebody mentions, I've had an intrusive thought that really worried me and scared me, or I had a thought that, gosh, life could kind of be easier. Life's really hard right now, but I would never do anything, to I've had a thought, I have a plan, I have the means. We're kind of looking at that range when we're screening. Recommendations just for anyone in the perinatal period, not just for suicide, psychosis, is we want to make sure that we're getting good screening early on and regularly, just as a protective factor as well. So it's recommended through Postpartum Support Internationals, where I did my training. Michelle, you did your training as well. They're a great resource, postpartum.net, resource for clinicians, therapists, if you want to get more training. They're also a great resource for families, for new moms, for birthing people, for parents. There's some free support groups there, so that's a great resource. But the recommendation from Postpartum Support International would be at the first prenatal visit, at least once in the first trimester, prenatal visit, second trimester, third trimester, 6 weeks postpartum, or at their first visit, and then repeated screenings at 6 and 12 months in the OB or primary care setting, and 3, 9, and 12 months at a pediatric visit. And typically the pediatricians are the ones that are seeing a lot of pediatricians, lactation consultants, and us therapists, if we are seeing the client already. We're the ones who really are getting a good kind of eye and lens on the mom, the parent, because we see their baseline. We know how they normally present, and we'll see any subtle changes or big changes. And so the pediatrician, a lot of new parents, hopefully they go to all their appointments, but if they're going to go to any, most of them are going to their pediatric appointments. And so those pediatricians, and they're doing a really good job. I'm talking to different people, different clients, different pediatricians themselves are doing a really good job screening, and I love that. But it's also recommended that anyone else in a medical or mental health care setting also do screening. So that can be a doula, a lactation consultant, psychotherapist, anyone else who's working with the family before, during, and after pregnancy. So, okay. Any questions so far? I don't think we have any so far, but just wanted to check in. So now that we know, it's kind of the foundation. That was a really quick overview of Perinatal Mental Health 101. When we're looking at screening for suicide and psychosis, the most important first step is, if you're comfortable, if you're a therapist, most of us were trained to be comfortable. That's our job. If you are a family member, a support person, caregiver, you might not feel comfortable, and that's okay. We understand. We want you to have this information and know how to get your person to the right place where they are with someone who feels comfortable asking these questions. But you want to be clear. You want to be direct. You want to be warm, open, and specific. So sometimes I'll hear people say, you're not having any thoughts of, that thing, right? And then it's like, move on from it, right? Or the person's like, no, I'm good. Or you've never thought about hurting yourself, have you? No, you wouldn't do that. We want to ask a direct question. So we want to ask, are you having any thoughts of not wanting to be alive, or thoughts of death? That's the kind of the first way that you can ask. And it's not as direct, but it's kind of an opener where it's a little bit more safe to say yes or no, or maybe, or I don't know. Then from there, if the person says yes, maybe, if there's some, kind of ambivalence, we might say, are you having specific thoughts on how to harm yourself or how to kill yourself? And then we allow them to respond. Have you thought about how you might do this? Do you have a plan? That's another question to ask. So are you having any thoughts of wanting to hurt yourself, not be alive, or thoughts of death? Then are you having specific thoughts on how to harm or kill yourself? Have you thought about how, or do you have a plan? Then from there, if the answer is we want to ask, do they have means? Do they have a way, a method, a plan, intent, access to weapons? We ask, as therapists, we ask all these questions. And as therapists, we want to make it safe for the person to answer. We're not, a lot of times what I see happen is we'll start with point A, which is the question, and then immediately jump to point C, which is the, let's get you to the hospital. Let's start calling people. We need to be in between in the B area where we're really asking more questions, getting information. We are giving psychoeducation. We're talking about, you know, suicidal thoughts can be common. Suicidal thoughts can be scary. There's nothing wrong with you. You're not bad. We're really trying to create safety in that conversation to get more information about what's going on. Also, something to be mindful of is when we're looking at something like a manic episode or a psychotic episode, psychosis, which is what we typically see in the news. And unfortunately, we see the more serious, very sad stories in the news, and typically it's something like that is going on. But we want to see, are they having a break from reality, out of touch with reality? Are they seeing things, hearing things, having odd, bizarre beliefs, delusional thought content? Something, they're just not themselves. Has their sleep been really disrupted where they're not getting any sleep, but maybe they're very energized still? That would be a flag for me to look at what's going on. If they are anxious and want to be sleeping and they feel exhausted, but they can't sleep, that's also something I'd be looking at. And the clinician and family member observation is really important, because sometimes what the client might, you know, the 4th trimester pregnancy, there's a lot going on. It's just like a big bubble of, you know, it can just feel like you're in a cloud of chaos, or, you know, kind of detached from yourself for a while. So sometimes you need somebody who is there with you, who maybe is a little bit more clear and can kind of help. So their observation of what's happening. So if you're a clinician working with your client weekly or every other week, and you see them pretty consistently and you notice a change, you would be that observer. If you're a family member who is really concerned about your family member seeing something that's off, different, a big change in behavior, we want to be looking at that. If they have suicidal talk, psychotic behaviors or talk, we definitely want to be looking at that. So, okay. So then what do you do once that happens? You know, as therapists, we're trained to know typically what to do with a suicidal client. If not, if you're in a, you know, someone who's still learning, you know, definitely recommend you seek consultation, supervision. If you're still working towards licensure, absolutely. So follow the steps and the protocols that, you know, wherever you're working and you're providing services. But if it's an emergency, a psychotic episode, they're out of touch with reality, maybe a manic episode, or they're suicidal with means, plan, intent, we want to, this is immediate. This is 911, go to the emergency department, nearest emergency department. And whatever feels safe. If the person has someone who can get them there, if that feels safe, you know, and we think that's safe, do that. If we have to call 911, that's not always, doesn't feel like the best option. But if all the other options are not safe, then sometimes that is what we have to do. And I want to add just the side note, and Michelle, you might be able to speak to this, is sometimes those emergency departments and psychiatric spaces are not the most ideal spaces for our clients. Some places are not perinatal trained or trauma informed trained, and it can be more traumatizing. But in the moment, the most important thing is getting the client to safety and stabilized, and then getting in there with that. Did you want to add anything to that? I feel like I know, you know, you would have some good information and input on that.
No, I think that's really good. And yeah, it's the ER is better than nothing, you know. And there is the 988 mental health crisis line as well.
Yes.
So just to make sure everybody's aware of that.
Yeah.
And, you know, like you said, therapists, mental health professionals usually have your protocols or kind of your go-to resources in your community, have those really accessible and available for people. I wondered, Kara, if you had any suggestions for the people who might, you know, be here, who may have joined us, who are not professionals, lay people, loved ones, family members, friends. What do they do?
Yeah. So if you are a support person, a person in that family's life, you know, the first thing, because we want to jump to point C. And now if it's an immediate emergency and the person needs to be safe right that moment, it's 911, the emergency department. If we're talking with somebody and they're just expressing, not just, but they're expressing their emotions, their feelings, There's like, I don't want to do this. I don't want to act on this.
Mm-hmm.
Listen, being present if you have the capacity to do that, because sometimes we don't. Sometimes this can bring up our own stuff. This can be too heavy for us. But if you can have some sort of capacity just to listen and just to be a supportive person, ask them what they need, ask them what they want, ask them, how can I support you? How can I be here for you? Let them know that you love them, you care about them, you're worried, that you want to help them. You know, just being there and holding that space can be that B step, right? Instead of jumping to C.
Mm-hmm.
So
Yeah.
being that safe person, if you're able to do that, can be important. And then, you know, I'm going to share a couple of resources because there are numbers and hotlines that you can call with them. So I work with Postpartum Support International. Postpartum.net is a website. There is a talk line that's 24-hour upfront. I have people directly call for themselves that maybe aren't in emergency 911 crisis, but they are in a crisis. And I also have family members. I have a friend with me. I'm really worried. I don't know what to do. And you can access those lines and help and sit with them and call with them and say, let's do this together. Let's find you some support, and look for a therapist long-term, help them make an appointment to go see their doctor, their psychiatrist, if they already have one,
Mm-hmm.
get in professionals, let them know what's going on, maybe write down a few symptoms that are coming up so that we have it in a place. You know, we don't have to go off of memory when we go to the hospital or the doctor's office. So there's things that you can do. It's not your job to fix it, to make it go away, but you can be a support person for them. And as far as therapists, we often will do safety planning, but safety planning basically means that we're going through who can you call, what are your coping skills to maintain your safety. If you feel like you're in crisis, you know, we're not really at the level of 911 emergency, but what can we do to kind of distract and avoid in the moment, and then get a therapist who can help you so that that's not the only coping skill that you have long term. Because it could be that there's a need for a full assessment, mental health assessment, and longer term care. So.
Absolutely. And if it's a situation where maybe someone is not feeling actively suicidal, but they are struggling with postpartum depression, they are starting to have thoughts of, oh, maybe it'd be better if I wasn't here, what we would call kind of a low acuity
Mm-hmm.
suicidal ideation. You can also talk to your OB,
Mm-hmm.
or, they're very, I shouldn't say very, but most are at least somewhat experienced in treating
Yeah.
postpartum depression and other PMADs. So,
Yeah.
um,
Usually recommend going to, if they've already they're established with a therapist, a psychiatrist, of course you go there. But if a lot of people aren't,
mhm,
and so the OB/GYN is often, sometimes I'll even say, because they've had an eye on them for the last year during their pregnancy, and so they kind of know their baseline, and they may have a little bit more training than maybe their general practitioner, who has to know a lot about a lot of different things. So
absolutely. And, if they do determine that an antidepressant or other medication might be a good fit, the OB is going to be a good starting point, at least for, things that may be safer during the perinatal period, or, with breastfeeding or things like that. Not to say they're the end all be all, but they're a starting point.
yes, absolutely, absolutely, yeah. And some resources, I did mention Postpartum Support International. There's a suicide prevention lifeline. You can text TALK, TLK, to 741-741. I'll put that in the comments wherever we share this video. I'll go ahead and go in the comments later today and add some resources in there and websites, so that way everyone has it right in one spot.
Perfect. Yeah, if you could put those in there, Kara, and then pin that comment so it's right at the top, that'd be
Yeah,
fantastic.
I'll do that. Yeah.
Yeah,
Thank you.
yeah,
Well, thank you.
absolutely.
So I'll probably in our group.
Thank you so much for being here. This is so important. And this is one of those topics that really, like you said, it's really sensitive and it can be stigmatized. So it's important to just talk about it, to say it out loud,
Yeah.
and to know that, like you said, your therapist is not going to freak out and overreact and put you in the hospital if you talk about having these kinds of thoughts. Therapists are trained
Yeah.
to assess for, how serious those thoughts are. And if they are serious, then it is an emergency.
Yeah. And one thing I'll just kind of add is, with my clients, when we start talking about, when I ask the questions, I always kind of do an informed consent that, hey, your experience may have been that as soon as this topic got brought up, we went to the emergency room. And I just tell them the difference. This is the criteria that is needed to make emergency hospitalization. It would be plan, intent, means, you know, out of touch with reality. And then talking about ideation and thoughts that come up that you feel maybe guilty or shame about or whatever. We can talk about that all we want in session. And we don't have to, we're going to crisis mode. We can sit and talk about that and really talk about it.
Oh gosh, we could go down a whole rabbit hole here. But what that makes me think of is, you know, in the perinatal training that I took, one of the things that really struck me was what you're talking about. It's called ego dystonic versus ego syntonic thoughts. And ego syntonic thought is a thought that you're okay with. So like, I've decided this and I'm okay with it, and I really feel like it's what's best. And a lot of times the things that we see in the news are, you know, people who, because of psychosis or severe PMADs, like they have decided that this is what's best. And whether it's taking their own life or their children's or, you know, someone else's. Whereas the mom who comes in, or, you know, the parent who comes in to talk to their therapist about, oh my gosh, I'm having these thoughts and it's terrible. You know, I'm very distressed by these thoughts. Then, like you said, we can talk about that all day long. That is likely the person who is in a lot of pain and is looking for help.
Yeah. And what they really need is to have space to talk about those thoughts. And not, like, because people get really uncomfortable and we want to shut it down because we think if we talk about it, it's going to make the person want to do it.
Right.
Versus it becomes the opposite of, the more we create space for it and talk about it, it can bring down some of the symptoms, you know?
Yeah.
Yeah.
Yeah. Yeah, definitely.
Well, thank you for having me.
Of course. Yeah. Thanks for coming on. Our first ever Instagram Live Inside Expert. I'm going to say it was a success. Yes. And if anybody out there watching has ever been a client or a student of mine, if you've purchased anything from me, if you've done coaching, if you've been in any of my programs, even like within a bundle, then you are invited to be an Inside Expert too. It's a great way to shake off the nerves with going live like this. It's a great way to get your message out there, to practice teaching people about the things you're passionate about, and to just get more visible and get your name out there. So if you're one of those people, reach out to me. Let's schedule your Inside Expert training. Okay?
Thank you for having me.
All right. Thanks, everybody. Have a great day. Bye.